So my name's Felicia and I'm a Senior Editor at Therapeutic Guidelines. I hope everyone's enjoyed the first session. The second session is set to be very exciting, so exciting to me maybe, not to others, but anyway. So without further ado, I'd like to introduce Nathan Ryder to the stage. Nathan is a sexual health physician in Newcastle. He is the head of the STI program unit with New South Wales Health Response for clinical and public health programs related to STI and HIV prevention, care and management. Nathan has conjoined academic positions at the University of Newcastle and New South Wales. Today, Nathan will be discussing mycoplasma genitalium and syphilis.
Okay, thank you. All right, so how do I steer it? Is it this one? Yep. All right, so yeah, I'll be talking about mycoplasma genitalium and syphilis. So they're obviously two sections of the STI part, and they're the bits that I think there's been some changes. Probably, at least from a personal point of view, that's what most of the calls I get from GPs for advice are. So I thought that'd be a good thing to focus on. This part is definitely written for primary care, so I think it's a bit of a shifting gear from some of the talks we've had. I won't mention breakpoints, be disappointed. But yeah, this section gets a lot of use. I know from research we've commissioned in New South Wales Health that the GPs use this section all the time, and it's really important that we get it right. So I'll start with testing recommendations around mycoplasma genitalium. So it's quite a common infection. So around 3.7% of women of reproductive age have the infection, according to data from community settings. But we don't really know that it causes a lot of harms. And so even though it's common, we really don't want a lot of testing to occur because excessive testing is leading to excessive amounts of antibiotic use, we think. So we've made it clear that there should be no screening of asymptomatic people and that we should be testing people with conditions that we are pretty confident are causally associated. So I've listed the ones there. There is data showing it's associated with reproductive health outcomes and adverse birth outcomes, but the group wasn't confident that they're causal associations. And more importantly, there's absolutely no evidence whatsoever that treating an asymptomatic person will prevent those. We've deviated a little bit from the national STI guidelines in that we've focused on persistent urethritis rather than all urethritis, and that's from feedback from primary care that it's difficult to treat. And so if some of the urethritis cases have already responded, we probably don't really want to know if they've got mycoplasma. So the big issue is antibiotic resistance. So resistance is super common and getting more and more common. I put up the latest percentages there. We know that the resistance is a combination of both clonal expansion plus resistance that induced during the course of each treatment episode. Most labs will perform reflex azithromycin testing, so there's two well-categorised mutations that define that, and so that's easily done as a commercial assay. Quinolone resistance is not widely available. There's a few mutations in PAR-C and GRA that drive this, but it's not as well understood, and there's no commercially available test. So whilst you will sometimes see that in research papers, you can't get it done. So in terms of managing, we really say you should be focusing on treating symptomatic cases. So if you've got an asymptomatic case, which by and large you probably shouldn't have if you followed the testing recommendations, but we know sometimes there are. And it is recommended to test ongoing partners of people with a symptomatic case. So if you've got a positive result in a person without symptoms, you would only consider treatment in these situations, and we've split it to recommending treatment if you're an ongoing partner of a person that had symptoms, and then considering treatment for pregnant patients who don't have symptoms. Okay, and that's because there is some data around adverse birth, but we don't know that treating will prevent that, and obviously a lot of the time using antibiotics that have problems in pregnancy. So consider treatment. So the treatment recommendations are pretty well defined now, and this is exactly the same as what's in the National STI guidelines. So it's a pre-treatment course with doxycycline followed by either azithromycin or moxifloxacin, depending on whether there's known or suspected macrolide resistance. And remember, 60% of cases currently have that. Probably one of the more common questions I get is, does it have to literally follow on? Does it matter if there's a gap? Because commonly it's going to happen that way, right? Because the result doesn't come back immediately. So there's limited data to base that on. Some published guidelines have suggested it doesn't matter. Just my view, it's about reducing the organism load. That's why we're giving it. And we know that from test of cure data that the organism load stays low for around 3 weeks. So it probably doesn't matter if there's a bit of a gap. You just follow through. If they come back after a long period of time, you're probably going to start again, but you probably should seriously think about whether they still need treatment by that point, because many people's symptoms will have resolved. So there's a section around advice to patients, and so we really ask them to abstain from sex, and this is where we deviate a little bit from the STI guidelines, because either until treatment's completed or the test of cure result is negative if it's done, because we didn't recommend a test of cure for everybody, and that's because we don't really not looking to detect it in someone whose symptoms have resolved. So we focused on the group of patients there. So that's a combination of people who have persisting symptoms, but also people that theoretically at least have an increased risk of harms associated with untreated infection. So we're suggesting to do it at least 14 days after treatment completion, and that's because of that issue with the organism load dropping after treatment, even if there's treatment failure. And if you test too early, you'll get a false negative, which defeats the purpose of doing a test of cure. But by and large, trying to move away from doing a test of cure in all patients. So treatment failure. So we haven't listed doses for treatment failure, okay? These are the drugs that there is recommendations around it in the literature. Pristinamycin and citalfloxacin have been reasonably well studied, and so there is quite clear dosing schedules that work. Minocycline is purely case series data at the moment, but that said, pristinamycin and citalfloxacin are almost impossible to get your hands on. I know in my district we've got an agreement that we will not use it for mycoplasma because we don't believe it's serious enough to warrant using our limited supplies. Obviously, on a case-by-case basis, that might not be the case, but so far we haven't used it. So we're using a lot more minocycline in practice because we can get our hands on it. So as I said, the guideline doesn't list the doses. It says call an expert. I'm assuming you guys are all the expert. So as I said, there's a lot of published data. Melbourne Sexual Health Centre keeps updated treatment lists for all of these things, and that's probably my go-to spot if you need to remind yourself of the dosing schedule. Sorry, but just before I jump to syphilis, so can I go back? No, okay, just stay on my for a second. In that group of treatment failure and using those other antibiotics, that's where when a GP calls, 9 times out of 10, I'm suggesting maybe you don't treat. And so there's a whole section now there in this guideline around discussing, do you really need to treat this person? Is it going to help? And I noticed from my clinical practice, majority of patients, once I've had the explanation around this, do actually accept that. And that's definitely changed the way I'm approaching this, and I'm using a lot less moxifloxacin than I used to. So syphilis. So syphilis is the other big topic. Hopefully you guys are well aware of the changing epidemiology. So the rate of syphilis has, particularly in gay men, just increased dramatically since the late 90s when we've got successful HIV treatment. But more recently, it's spread out into the population. So we first noticed an increase in cases in remote Aboriginal communities, but now it's pretty broadly spread across the country. So we're seeing more and more cases in heterosexual people who don't have any of the sort of classic risk factors. So the big message that we want people to think about is to think about syphilis in situations where you previously wouldn't, in people with symptoms that could potentially be related to syphilis. Now, the big problem, of course, is that because there's a lot more syphilis in heterosexual populations, that we're seeing more congenital syphilis. and the rates of that's been going up nationally and it's continuing to go up. I know we've had several cases in New South Wales in recent times. Now, with syphilis, one of the more challenging things for GPs is diagnosing it, because I'm sure you all know that serology is complicated to interpret if you're not used to it. We haven't gone into great details, but we have explicitly linked to some really good tools that are out there. So if you haven't seen it, the decision-making tools that ASHM put out have really clear step-by-step guides of how to interpret the serology, which is really useful for people who are not doing it all the time and junior staff. So the other big issue currently is the shortages of benzathine penicillin. So that's a global problem and has recurrently occurred in Australia over the last couple of years. I think we handled it pretty well. So there was really good conversations around how to ration the usage, RHD and syphilis being the two biggest use cases. We've had pretty good access to imported stock. And I just actually got an email this morning that another shortage is expected, I think, starting May. So probably going to be going again. So the big thing here, though, is to link to experts. So your average community pharmacist and your average GP cannot navigate this. And so we really push that they should call for help. So all states have sexual health clinics, all states have public health units that can help navigate this. Because without that help, people tend to use weird things. And that's partly why we haven't given recommendations for other doses. I actually just got called last week by a GP who couldn't get it. So he looked up the US recommendation for ceftriaxone. So he started that, but then he realised he couldn't see them on the weekend. So he just gave the same dose over a contracted number of days and thought, well, that'll be fine. But clearly it's not, for the reasons discussed this morning, that it's time dependent. So yeah, it's tricky. So the alternative agents, so we do give a dose for doxy. That's pretty well categorised that, what it is that you use, so we feel comfortable with that. We do explicitly say you cannot use that if they're pregnant, so there's no alternative regimens listed for pregnancy. We don't go into the details of the ceftriaxone dosing. The British and the American guidelines do provide some guidance there, but they do point out that there's not a whole lot of data to back it up, and there's really no clinical data in pregnancy. So they very, very clearly recommend not to use that if you can avoid it in pregnancy. But outside of pregnancy, it would be reasonable to use ceftriaxone. It is daily dosing for 14 to 21 days, so it's not that practical. But the general advice in the therapeutic guidelines is that you should be seeking help for this. In terms of syphilis in pregnancy, which probably won't predominantly be something you guys are doing, but just thought worth highlighting the trend. So all states have moved towards multiple points of testing. So in the national guidelines, it still only recommends a single point of testing, but in practice, all states have moved towards at least 2 times. And the pregnancy care guidelines being reviewed right now, and it looks like it might go to 3. As I said, very, very clearly states no non-penicillin regimens are recommended. And in terms of what's driving these congenital cases, it's really low engagement in care is the main problem. So getting people to come, get tested, and then follow through all their treatment. Which leads me to the last point, which is probably where you guys come in. So one of the things we notice in our investigations of the cases that do occur is often there's failure of communication and handover between teams. And so if you think about it, it's got to go from, often it's the GP testing, they might treat, or they might get into maternity who treats, sometimes sexual health gets involved, but then got to be followed up through pregnancy with repeat testing to check that worked. Someone's got to treat their partner, so that's usually within the maternity space. But then they get delivered and the paediatricians get involved, and so there's got to be handover. Sorry, a bit too excited. So there's got to be handover there between the maternity team to the paediatrician, and then they get discharged and they need follow-up there, which is usually the GP, and so that often falls off there. So we're really pushing that we need to do better, and this is primarily a hospital problem, around clinical handover and communication between teams for women who are diagnosed with syphilis in pregnancy, and especially high-risk babies that end up needing follow-up. So my last slide's on DoxyPEP. So DoxyPEP, there's a few studies and a systematic review showing how effective it is. It was actually all getting published around the time we were meeting, which was quite challenging to know how to navigate this space. So we have a section there that discusses what it is, what it does, which is a 75% reduction in chlamydia and syphilis. It doesn't actually list the dose in the section in the guideline, but it does give an indication of when you might think of using it. And we're conscious that many gay bisexual men are using this. There's a lot of people just getting it and using it, not following a normal dosing schedule. So it's better if they're getting accurate information, we feel. But until there's a national guideline, I think that the thought was it shouldn't have the dosing schedule in here. Most use is probably within sexual health clinics and GPs who focus on gay bisexual men in their practice. It's probably not widely used. But we think it's important for that reason that it's being used, and we want good evidence-based practice. But the other thing is that from a population health point of view, I think it's actually really important that we do, try and promote the effective and proper use of this, because in the states where they've had a bit earlier and more widespread uptake, they're seeing quite significant population level decreases in syphilis that we're just not seeing through any other intervention we're doing. So it's hard to ignore this as an intervention, even though we know that there's some serious risks there around antimicrobial resistance. So the guidelines currently that are out there, and like I said, there's no Australian one, is recommending, and this is in line with what we've written in this section, that it's not broadly promoted for everyone, but that it's considered on a case-by-case basis on a shared decision-making basis. Okay, so rather than having clear black and white, this person gets it, this person doesn't, so it's shared decision-making around the risks and benefits to that person. But yeah, conscious it's probably one of the more controversial points of the chapter. Yeah, that's it.